inflammatory disorders of breast. We will discuss acute mastitis, breast abscess, ductectasia, plasma cell mastitis, eosinophilic mastitis, granulomatous mastitis, fat necrosis, lymphocytic mastopathy. Inflammation of the breast is called mastitis. So acute inflammation of the breast is called acute mastitis. Acute mastitis is usually seen in the first month of breastfeeding. During this period, the breast is vulnerable to bacterial infection due to the development of cracks and fissures in the nipple. These cracks and fissures act as a route of entry of various organisms like Staphylococcus aureus or less commonly streptococci, which invade the breast tissue. The breast is erythematous and painful along with fever. Initially, only one duct system of the breast is involved, but if left untreated, the infection may result in single or multiple breast abscesses. Morphological features. Staphylococcal infection produces a localized area of acute inflammation that may progress to the formation of a single or multiple abscesses. Streptococcal infections may tend to cause a diffuse spreading infection that eventually involves the entire breast. The involved breast tissue is infiltrated by neutrophils and may be necrotic. Most cases of lactational mastitis are easily treated with appropriate antibiotic therapy and continued expression of milk. Surgical drainage is rarely required. Now, this is the photograph of acute mastitis, which shows the presence of acute inflammatory cells, and there is a duct which is marked with blue arrow, which shows the formation of micro abscess. Subareolar abscess. This condition is known by a variety of names, including recurrent periductal mastitis, squamous metaplasia of lactiferous ducts, and Zuska disease. This condition is located in the subareolar or periareolar region and can develop in both lactating and non-lactating women. It can be seen in women of any age, but more common during reproductive years. It may present as a painful erythematous and oedematous lesion of breast. Most organisms responsible with the formation of breast abscess include bacteria such as Staphylococcus, Proteus, and Streptococcus species. They have a tendency to reoccur and may extend to form fistula. In 20% of cases, the lesion is bilateral. Recurrences develop in almost 90% of cases. The nipple is inverted or retracted, can be seen in more than 50% of cases. Microscopic features. It is a localized and relatively well circumscribed inflammatory infiltrate, mainly composed of neutrophils granulocyte in the center of the lesion. Macrophages, lymphocyte, plasma cells are also present, but they are at the periphery of the lesion. A foreign body type of giant cells may also be seen. A fibrous capsule may also be present. Mostly, there is a complete replacement of glandular epithelium of the lactiferous duct by extensive squamous metaplasia and obstruction by keratinous cellular debris. Now, this is the diagram which shows that there is squamous metaplasia which is extending into the duct which is plugged by keratin, and beneath that there is abscess formation along with opening of fistula. This photograph shows the histological features of subareolar abscess, in which there is squamous metaplasia of the lining of the duct marked with red arrow, and the black arrow shows presence of necrotic debris. Ductectasia, mammary ductectasia, or plasma cell mastitis is a disorder of the extralobular ducts. In this condition, when a milk duct beneath the nipple widens, the duct wall thickens and the duct fills with fluid. It is characterized by pain, nipple discharge, which may be clear, cloudy, greenish, or blood-stained. There can be nipple retraction or a palpable mass beneath the nipple which has a dough-like feeling on palpation, so giving the sensations as we are palpating the bag of worms. It is usually seen in multiparous women after 40 years of age in both perimenopausal and postmenopausal women, or several years after cessation of lactation. Pathogenesis. When seen in postmenopausal women, the primary pathological process is gland atrophy leading to stasis of secretions, which results in leakage of lipid-rich material through the duct wall and resulting in periductal inflammation. However, there is another opinion that periductal inflammation is the initiating process, which is followed by ductal sclerosis, obliteration, and finally ectasia. Gross appearances. It may present with acute onset of breast tenderness, redness, and nipple discharge. After the acute episode, there is an ill-defined area with large dilated ducts containing thick, creamy, white to yellow secretions, which simulating like chlamydo-necrosis, and there is a pitfall that we are dealing with chlamydocarcinoma. Microscopic features. There is severe, diffuse plasma cell infiltrate which surrounds the ducts and lobules. It is characterized by varying degrees of periductal inflammation, periductal fibrosis, and duct dilatation. There is a presence of foamy histiocytes within the luminal secretions which infiltrate the wall of the involved ducts. The periductal inflammation is mainly of plasma cells, which is due to intense plasmacytic reaction to secretions of the involved ducts. There is often hyperplasia of ductal epithelium. Areas of necrosis may be present. There may be a histocytic reaction which can be accompanied by giant cells. The granulomas may or may not be present. Lipid-rich and thick intraluminal secretory material is associated with desquamated epithelium. There is variable presence of neutrophils and lymphocytes. It is used to be called as mastitis obliterans and chlamydomastitis. Now this is the photograph showing histological features of duct ectasia. You can see dilated ducts which is filled with granular debris with the presence of lipid-laden macrophages. Another microphotograph which shows dense lymphoplasmacytic infiltration around a lobular unit, and also xanthomatous reaction can also be seen. Now this is another photograph which shows obliterated duct lumina seen in the final stages of mammary duct ectasia. This is also called Garland sign, in which the ducts are obliterated by the dense surrounding fibrous tissue along with inflammatory cellular infiltrate. Now there is another photograph which shows the duct is compressed by the surrounding fibrous tissue containing secretions, which is shown by yellow arrow, whereas the surrounding fibrous tissue and chronic inflammation is shown with red arrow. Now why duct ectasia is important to be recognized? Because it is mistaken for carcinoma. Its gross appearance, that is the presence of thick creamy material, may be mistaken as comedocarcinoma. Nipple discharge of thick secretion, nipple retraction, and oedematous skin changes usually associated with an ill-defined firm to hard mass which closely resemble inflammatory breast cancer. Ulceration of the skin and fistula formation may also occur. Eosinophilic mastitis, a rare type of mammary inflammation which is characterized by extensive eosinophilic infiltrate around the ducts and lobules. Microscopic features, massive infiltration of eosinophils around the ducts and lobules. Lymphocytes and plasma cells are often mixed with eosinophilic infiltrate. A granulomatous reaction may rarely be seen. The involved ducts and lobules may display reactive epithelial changes with enlarged nuclei, high nuclear cytoplasmic ratio, and prominent nucleoli. There is no morphological evidence for a parasitic infestation. Now, this is the photograph. You can well appreciate large number of eosinophils which are present in between the lymphocytes and neutrophils. Granulomatous mastitis. Granulomatous inflammation is present in less than 1% of all breast. Usual causes include systemic granulomatous diseases like Wagner's granulomatosis or sarcoidosis, which sometimes involve the breast. Granulomatous infections may be caused by mycobacteria or fungi, which are very common in immunocompromised patients, or adjacent to foreign body objects such as breast prosthesis or nipple piercing. Now another entity which is granulomatous lobular mastitis. It is an uncommon breast limited disease which is only seen in PARAS women. It appears after pregnancy. It mostly presents about 2 years after postpartum, but may be seen many years later. It typically presents as a distinct hard breast mass which clinically mimics carcinoma. The granulomatous inflammation is confined to the lobules, which may be caused by a hypersensitivity reaction to antigens expressed by lobular epithelium during lactation. Gross appearances: it presents as a firm to hard mass and its usual location is at the periphery. The mass often has a nodular architecture which measures up to 8 cm in size. Microscopic features: granulomatous inflammation in and around breast lobules, called Granulomatous lobulitis. Inflammatory reaction which consists of granulomas, multinucleate giant cells, plasma cells, and eosinophils can be seen in the lobules. Fat necrosis and small abscess formation are rarely seen. Now this is the photograph which shows microscopic features of granulomatous mastitis. The presence of granuloma is marked with black star, whereas dense inflammation is marked with red star. Now in this photograph, the microscopic features of granulomatous mastitis are seen at high power. Granulomatous reaction is marked with word G, whereas the ducts are marked with D, which are surrounded by dense lymphocytic infiltrate. Now I must point out here that whenever you find granuloma, you must go for Gamure's methenamine silver and PAS to rule out fungus and tissue AFB to rule out Mycobacterium tuberculosis. Fat necrosis of breast. It may present as a painless, palpable breast mass or with breast tenderness. It clinically or on mammogram may mimic breast carcinoma. It is believed to be related to trauma, most commonly previous breast surgery or after aspiration of cyst, radiotherapy, use of warfarin or breast infection. Gross appearances, it is of small size, about less than 2 centimeter. The lesions are either single or multiple, firm, round or irregular masses with tan yellow streaks and often areas of dense fibrosis. Hemorrhages may be also seen. Cystic degeneration and calcification can also develop. Microscopic features. Acute lesions are hemorrhagic, containing central area of liquefactive fat necrosis. There are abundant lipid-laden and foamy macrophages surrounding small cystic spaces. Foreign body giant cells and chronic inflammation consisting of lymphocytes and plasma cells are also present. There is fibroblastic proliferation and collagen deposition seen in the older lesions. Similarly, scar formation and peripheral calcification, described as eggshell calcification, appearing on mammogram, are the late manifestations. Special stains and immunohistochemistry. CD68 histocytes are positive, S100 protein negative, cytokeratin negative. Now, these are the photographs which show microscopic features of fat necrosis as labeled, and another photograph showing lymphocytes and plasma cells along with giant cell. Lymphocytic mastopathy, sclerosing lymphocytic lobulitis, and in certain literature it is mentioned as diabetic mastopathy. This condition may present with single or multiple hard palpable masses. These masses are bilateral in 50% of cases and can be detected as mammographic densities. Gross appearances. The lesion present as a hard, non-tender, freely mobile breast mass. The lesions are at times so hard that it can be difficult to obtain tissue with a needle biopsy. Microscopic features. They show collagenized stroma with proliferation of benign appearing fibroblasts surrounding atrophic ducts and lobules. There is no cytological atypia. Lymphocytic infiltrate around small blood vessels in and around lobules and ducts is seen. There is also thickening of the epithelial basement membrane. This condition is most commonly seen in women suffering from type 1 diabetes or autoimmune thyroiditis. So, hypothetically, it has an autoimmune etiology. Its only clinical significance is that it must be differentiated from breast carcinoma. Now, this is a photograph which shows microscopic features of lymphocytic mastopathy. You can well appreciate that there is a duct which is labeled with letter D. There is lymphocytic infiltrate marked with letter I surrounding the duct, and in the periphery there is dense fibrous tissue marked with letter F.